Good afternoon. It's an absolute honor and privilege for me to be here today to speak to you about colon cancer and how we treat colon cancer in the United States, specifically stage 2 and stage 3. I want to thank the meeting organizers, Dr. Restrepo. I want to thank you all for allowing me to come here today. We live in the era of individualized medicine. Our patients are coming and asking, do I need to have treatment? What kind of treatment do I need? These are very critical questions, and we live in a time when we have molecular data, not just clinical data, not just pathologic data. We have the next level, individualized molecular gene expression data to help make our decisions as to how patients are treated. So we're going to go through a very important test that we use in the United States, okay? And that's the Oncotype colon cancer assay. I'm going to start off with 2 patients. These are actual patients that were submitted, and I'm going to try to ask you, and I know we don't have the audience response, but I want you to think about which of these 2 patients would you give chemotherapy, okay? So we have a 63-year-old male, has a moderately differentiated cancer in the ascending colon, right-sided colon, 5 centimeters in size. It's a T3 lesion, so it's going through the bowel wall. Low grade, lymph nodes are negative. 26 lymph nodes were assessed by the surgeons. Mismatch repair proficient, no lymphovascular invasion, no perforation obstruction, no medical conditions, okay? So is this the patient that you would give chemotherapy to? Similarly, would you give chemotherapy to this patient, 56-year-old female, 6.5 centimeter tumor, T3, low grade, no lymph nodes, 13 were examined, mismatch repair again proficient, no obstruction, no lymphovascular invasion. So which of these patients do you treat, okay? Do you treat patient 1? Do you treat patient 2? Do you treat both of these patients? Do you treat neither of these patients, okay? We're going to try to go through how we decide how to treat patients, which patients to treat. Would you order any additional testing? For example, Oncotype DX. And what chemotherapy would you use? Would you use 5-FU? Would you use 5-FU and oxaliplatin, FOLFOX or FLOX? What chemotherapy would you use? Okay. This is the challenge that we face not only here in Colombia. We face this challenge in the US. The Europeans face this challenge. The Asians, the Koreans, the Chinese, they face this problem also. So what guidelines do we have to make this decision? These are the National Comprehensive Cancer Network NCCN guidelines. If you have a T3 tumor that has no high-risk features, you have the option of observing them or giving them chemotherapy. If you have a T3N0 cancer that is high risk, and we're going to talk about high risk at length, high risk or T4 tumor, it is recommended that they receive chemotherapy, either with 5-FU or oxaliplatin-based chemotherapy, okay? So those are the guidelines that we have. Not very helpful. We have this, that it has to be a discussion between the patient and the physician, that you have to sit down and talk to the patient and say, what do you want to do? Because we can't decide. But there are risks. There are risks of the chemotherapy. There's neuropathy with the oxaliplatin. There's risk of death with the chemotherapy due to neutropenia. There are a lot of issues that have to be discussed. And we do have some poor prognostic factors, okay, that help us make the decision whether to give chemotherapy. And I want you to hold on to that for a minute. Okay. So, the stage 2 colon cancer controversy and dilemma. It's a complicated discussion with the patient. You have to understand the patient's perception of risk, and you have to understand the oncologist and the surgeon's perception of risk. We cannot predict absolute risk. We cannot link risk and treatment benefit. I'm going to show you that these are not necessarily true. We can link risk to individuals and to treatment benefit. And what factors are most important? We don't know. Well, I'm going to try to teach you or tell you which important, how we use them and how it impacts how we practice. Okay, so does chemotherapy help stage 2 colon cancer patients? The answer is it does. It does help patients. This is the QUASAR study, a very large 1,400 stage 2 patient colon cancer only, and down here there is a benefit. It's about 5%. When you put it together, 5% out of 20%, that becomes significant. It's a 25% benefit in absolute terms, okay? So that is important. If we look at contemporary chemotherapy with oxaliplatin, FOLFOX chemotherapy, if we look at the endpoint disease-free survival, we see clearly here there is a benefit in stage 2 patients, okay? And if we look here with stage 3 patients, by adding oxaliplatin, we see a benefit here as well, okay? So again, chemotherapy does help patients, even if it's oxaliplatin. Now, if they looked at the overall survival, there was a minimal benefit. But clearly, in stage 3, there is a benefit. We just have to remember that chemotherapy needs to be given in a timely manner. It cannot be given 2 years later. It has to be given within 6 to 8 weeks. So it's very important that the patients come back and visit with us and that they get whatever testing is needed, they get it done quickly. It's important to recognize that most cancers will come back at 2 years. And so when the patients are in year 3 and 4, the chances of the cancer coming back are low, which is very good. We're trying to get the patients to 2 years, and that's when they're going to do best. Okay, so what are the existing tools that help us decide whether we should give chemotherapy? What are the existing tools as of today? Well, historically, we've looked at clinical pathologic features, okay? We've looked at T-stage. We've looked at bowel obstruction and perforation. We looked at mismatch repair, MMR, margin status, the number of lymph nodes assessed, tumor grade, lymphovascular invasion, perineural invasion, okay? If there are unfavorable risk factors, we will treat patients. We've done this for decades, okay? These are all prognostic factors. It's very important to recognize none of these are predictive. None of them are predictive for 5-FU. None of them are predictive for oxaliplatin. They're not predictive. They're prognostic, okay? Very, very important to distinguish the two. These are all prognostic factors. Mismatch repair in regards to prediction is controversial, but I'm going to show you what we do in the U.S., okay? All right, so only one marker, MMR, is recommended. All of these others are unable to predict 5-FU chemotherapy benefit. It has to be clear. Okay, so as we step into the realm of genomic assays, how do we understand and critique, accept what assays are appropriate? So the assay has to be fit for purpose. It has to undergo very clear analytical validation. It has to undergo rigorous testing, very straightforward. It has to have clinical utility. There has to be use for this assay. Does it help us decide whether chemotherapy should be given or not? It has to be validated clinically, okay? So these steps are necessary for us to employ or to use a test, okay, a tool. I'll just say that the group that we're talking about, the test that we're talking about today, has done all of these things in a very rigorous manner, okay? There are other assays out there, coloprint, they can't do this. They don't have the ability to do clinical validation. They don't have the ability to do analytical validation. Only one group so far has gone to the extra length, the extra work to do this, okay? That's why we believe in this test. The development and validation of the Oncotype DX has undergone various testing, okay? The developmental work was done on stage 2 patients, 1,800 I'll tell you that these are the specimens that I published, this group and this group, in 1998. That was the work that I did. They went back, gathered those specimens, and also got Cleveland Clinic specimens and NSABP specimens. They went on, we're going to talk about QUASAR, we're going to talk about CLGB, and then they went on and looked at oxaliplatin treatment. And then ultimately, how does this affect decisions, okay? Let's go through the data. All right, so this is the Oncotype DX recurrence score, okay? These genes are reported. These are, if these are elevated, they're bad. If these are elevated, they're good prognosis, bad prognosis, and then a genotypic assay, and one gets a recurrence score after all of this is added up, okay? So very scientific, started off with 700 genes, and we're able to identify 12 genes that were important in deciding outcome. Okay, so the validation study was in the QUASAR data set. QUASAR was all stage 2. We already talked about this. Patients received observation or they received 5-FU chemotherapy. The trial was in the United Kingdom, and there was about a 4% absolute benefit from chemotherapy, okay? Which ultimately, as I said earlier, is about a 20% relative risk reduction. That's significant. That's a significant number for those of us that worry about the patients having the cancer come back. 20% is too high. We need to reduce it. Okay, so QUASAR, 3,000 patients, about 70% of samples were available, okay? And so the final evaluation was about 1,400 patients. The primary endpoint of this analysis was to show that the 12-gene recurrence score predicted outcome in the form of recurrence risk, okay? And the primary endpoint was met. The primary endpoint shows this line, this curve. If you have a low recurrence score, you have a low recurrence risk at 3 years. If you have a high recurrence score, you have a higher recurrence, upwards of 20 and 25%. Again, these numbers are too high for a stage 2 patient, okay? Way too high. This means 1, 2 patients are going to recur out of 5. Too high. So the recurrence score helps us identify those patients that are at higher risk. The patients that have poor prognosis, okay? These are some of the multivariate analyses just telling us about, I consider these what they call internal controls. These help validate the data set. These help understand that this is a real, valid, acceptable outcome. So recurrence score predicts, as you go up in recurrence score, you have a worse or higher hazard ratio. P-value is statistically significant. If you have mismatch repair, of which 13% of patients have mismatch repair, your hazard ratio is favorable with a statistically significant p-value. So your hazard ratio is 0.32, okay? That's a very low risk of death from colon cancer. And I'm going to tell you several times today, we do not treat mismatch repair deficient patients in the United States. We do not treat them. Stage 2, we leave them alone. They have good prognosis, we give them no chemotherapy, okay? T-stage, this is well recognized by our surgical colleagues. T-stage, worst prognosis, okay? 15%, hazard ratio 1.83, statistically significant p-value, okay? So these are markers that you would expect good prognosis, poor prognosis, and then recurrence score to help us across a spectrum, across a line, a curve, to understand who's at risk and who is with good prognosis. Okay, so in the multivariate analyses, recurrence score, mismatch repair, and T-stage were most significant predictors of recurrence. Okay. Some more words on mismatch repair. This is the data that we did, Dan Sargent. What this shows is if you leave mismatch repair patients alone, DMMR patients alone, stage 2, their curve is right here. This is surgery alone. So surgery cures most of these patients, okay? If you give them chemotherapy, 5-FU, their survival is less. Their survival is lower, okay? So this is why we don't treat mismatch repair stage 2 patients in the U.S. because of the potential harm from chemotherapy. So the prognosis is good. Observe them. I'm going to tease you in this molecular age with this analysis. This is an analysis looking for MSI high-like, so defective mismatch repair-like patients. We potentially can double the number of these patients that have good prognosis, okay? The genomic health people are working on this in South San Francisco. I'm helping them with this project. Potentially, we can double from 15% mismatch repair to 30%. And in doing that, these again are patients that have favorable prognosis and that don't need chemotherapy, okay? Okay, so what do we do with this data? How do you incorporate this data? Again, T4 patients, I think everybody in this room would argue that we need to give them chemotherapy. MSI or defective mismatch repair patients, very, very favorable prognosis. Really doesn't go above 7, okay? We do not treat these patients, okay? When you get the report from the Oncotype colon assay, we don't really want to see this curve. It doesn't matter. If the patient is defective mismatch repair, we don't treat them. So we don't need to know this curve. We don't need to know what their score is. It doesn't impact what we do. Where it's critical, where it's very, very, very important, is this group of patients. This is the majority of patients, 74%. T3, the average colon stage 2 patient, T3 and 0, okay? But we don't know which of these patients to treat. That's the problem. That's the problem when I presented those 2 cases. We don't know which of those individuals need chemotherapy. But if we order and we conduct and get the result from the Oncotype test, if the patient has a high score, and by high score we're defining it as greater than 41, okay, this is 25% of the patients, their recurrence score is greater than 18, getting up into the 20% range, 25%, okay? So their recurrence score, their recurrence risk, is similar to the T4 patients, okay? So we would argue that these patients will benefit from chemotherapy and therefore should be treated. And that's how we practice. At Mayo, at other cancer centers in the US, if a patient has a high score, we will give them chemotherapy, okay? That's where this test is helpful, very helpful. Very helpful also if the patient comes back with a low score, okay? Because the recurrence is low. There's no real benefit from chemotherapy. So again, for a recurrence score of less than 30, right here, less than 30, the risk is less than 15%. So in the majority of these patients, the benefit is quite small from chemotherapy, and therefore we won't treat, okay? So it's very straightforward. If it's high risk, treat. If it's low risk, observe. And avoid the toxicities, the side effects, the anxiety, the patient worrying about chemotherapy. Very helpful, okay? And I'm going to show you some data how oncologists and surgeons changed their treatments based on this result. Okay. I said earlier that those high-risk features are not predictive. They cannot quantitate what the risk of recurrence is, okay? Lymphovascular invasion, differentiation, the number of lymph nodes cannot quantitate the risk. The score that results from the Oncotype colon assay can, okay? How does it do that? How is it actually predictive? What you see here is a low-risk patient, okay? If you give them chemotherapy, the benefit is low, okay? So the blue line here is surgery. The chemotherapy is the yellow. The difference from this line and this line is low, okay? Similarly, if you have an intermediate score, the difference from chemotherapy, maybe out here it's a little larger, but still it's not very different. Contrast that now with high risk. High risk, there's a larger benefit from chemotherapy, okay? So that's why this is helpful. If you have a patient with a high risk, their recurrence is lowered to a greater extent with chemotherapy. Okay, so that's how this is helpful. It tells us this difference in the two curves, this benefit from chemotherapy is greater than this benefit in these two curves in low recurrence risk patients. That's how we justify treating high risk, high recurrence score patients, okay? It's proportional. You can't do this with the number of lymph nodes. You cannot do this with proliferation. You cannot do this with lymphovascular invasion, okay? That's where this quantitative assessment, the numbers, the risk, are helpful. Okay, so to conclude from QUASAR, the continuous recurrence score independently, quantitatively predicts individual recurrence risk, provides additional clinical value beyond available measures. Its greatest utility is in T3 mismatch proficient patients, stage 2 patients, of which there's about 74%. This is a new paradigm for quantitative assessment of recurrence risk. I would agree with all of those conclusions. These were the conclusions from the QUASAR study. Okay, so we have one study. We're not satisfied with one study. We need more data. So we went on, or Genomic Health went on. We're going to go on and look at the CLGB 9581 trial, looking at the Oncotype score. Okay. So these patients, it's important to recognize these were low risk, stage 2 patients. They were observed or they were given an antibody a vaccine. 1,700 patients, and they were low risk, meaning they excluded T4 patients, okay? That's important to know. So these were not high risk, average colon stage 2 patients. That's shown here. The T4s were less than the QUASAR by at least a half, okay? Mismatch repair deficient was higher, okay? And then the recurrence score, the recurrence risk at 5 years was lower. So it's important to recognize the CLGB trial was a more favorable population. Nonetheless, when you did the primary analysis, primary endpoint, does the recurrence score correlate with recurrence risk at 5 years, you again see this curve, okay? So low recurrence, high recurrence risk, higher score, okay? Very important. And again, hazard ratio 1.52, statistically significant p-value, even in a more favorable population. Okay. Discriminating high versus low. High was about 22%, low 44, intermediate 33, okay? We know that most of the patients are low risk. This makes sense. 77% were low risk. The majority of stage 2 patients are low risk. The majority of them should be observed. It's these patients that we don't know who they are, okay? And we know that their risk is unacceptable. 21% is unacceptable. It has to be lower. It has to be in this range, okay? So again, validation of the earlier QUASAR data. So we have QUASAR now, and we have the CLGB data, okay? Let's go on. Now we're in the era of oxaliplatin. We don't just treat with 5-FU anymore. We treat with oxaliplatin. So current practice recommends 5-FU and oxaliplatin, FOLFOX, adjuvant therapy. Oxaliplatin benefits only a fraction of patients, somewhere in the 6 to 7% range. It has more toxicity, neuropathy, that can be lifelong. Patients cannot button their shirt, they cannot turn pages, they cannot close their eyes because their feet, the nerves are injured. This can be long-term injury from chemotherapy, okay? So who can we give chemotherapy, oxaliplatin, to, and who should we